Welcome to the Macular Degeneration Association seminar on Ask the Experts. This is part of a series of seminars we do for with virtual patient seminars for macular degeneration. Check our website at Macular Hope, HOPE.org for future virtual patient programs. This program is presented by two very distinguished doctors whom you will be able to ask just about any question you want about your problems with your eyes. I want to thank the two companies, Regeneron and Novartis, for their support of all these virtual programs. I also want to give you a little background about the Macular Degeneration Association before I introduce our speakers. First of all, the Macular Degeneration Association was founded about 12 years ago by myself because of the experience I had with my mother, who lost her entire central vision to wet macular degeneration about 20 years ago. The frustration that we as a family experienced with her losing her sight and not understanding what was going on motivated me to try to develop something for patients across the country. When I retired as a healthcare attorney in Washington, D.C., I decided to form the Macular Degeneration Association, and what you see now is part of our efforts to engage with the macular patient community. We have two very distinguished speakers today, both of whom are on our medical advisory board. One is Dr. Joshua Mali, and the other is Dr. Jeffrey Gerson. I'm going to introduce them both, and I want to give you their backgrounds, which are very impressive indeed, and I think you're very, very comfortable with their responses. First of all, Dr. Mali is our Macular Degeneration Association medical director as a retina specialist. Dr. Mali graduated summa cum laude in biology from West Virginia University, where he received the prestigious WVU Foundation of Outstanding Senior Award. He then continued at WVU School of Medicine for his medical degree and internship, in which he was awarded a Medical Scholarship Award. Upon deciding to specialize in ophthalmology, he proceeded to Albany Medical College for his residency and was elected chief resident by his peers and faculty. He completed his medical and surgical training as a retina specialist, and he now is a principal investigator for many clinical trials, including new treatments for wet macular degeneration, diabetic retinopathy, and uveitis. Dr. Mali was named 2020 American's Top Ophthalmologist, and also he currently practices with the Eye Associates in Sarasota, Florida. Dr. Jeffrey Gerson is the Macular Degeneration Association Optometric Medical Director, and he graduated from Indiana University School of Optometry in 1997, after which he went on to do VA residency concentrating on low vision and ocular disease. He has been in several different practice settings, including retina referral practice, where he practices in several large clinical trials. Currently, Dr. Gerson is in private practice. That is a collaboration of both optometrists and ophthalmologists. He sees primary care patients and has emphasis on retina care. It's now my pleasure to turn this meeting over to all of the participants. So without further ado, it's my pleasure to turn this over to our experts. Thank you very much.
Thank you, Larry.
Thank you, Larry.
I guess most of all, the most important thing is to thank everyone that's logged in for this today. I know, so I'm Jeff Gerson, and glad to be joined by my colleague, Dr. Mali. Our goal is to answer any questions that you have on your mind, and hopefully we'll be able to give you some good answers. Josh, we already have a couple questions coming in. So Mimi's asking, what are the symptoms of retinal detachment? My father had retinal detachment. What is my risk of having one? I have one eye of dry AMD and one eye wet.
Great. Thank you, Jeff. And again, thank you, Larry, and the Macular Degeneration Association for hosting this event. And that's a great question. You know, it's great because I can help with that. I'm a retina specialist. So first of all, a retinal detachment is a completely separate diagnosis than age-related macular degeneration. So these are two separate diagnoses. But I'll answer the question directly. So for retinal detachment, this is when what happens is, and kind of take a step back, look at the anatomy of the eye. What we're talking about is the retina, which is kind of the back. You can think of it inside the eye, the kind of back of the eye, and kind of the film or the I like to think about it like wallpaper on the back wall of the eye that helps all of us see. And there's also kind of in front of that is a kind of a jello-like substance called a vitreous, which sits kind of on top of that wallpaper. And with age-related changes and other various risk factors like being nearsighted and any history of trauma and so forth, what can happen is that gel over time can actually pull on the retina and it changes in a normal process from a solid to a liquid. And during this process, and some people, for whatever reason, it can actually pull kind of hard and cause a little hole in the wallpaper or a hole in the retina. And then a liquid gel gets through that hole in the retina and pulls the wallpaper off the wall. And that's what we call retinal detachment. When this happens, people can lose vision very quickly and very devastatingly from this as well. So I guess to answer the question, you know, again, it's hard to tell what their family history. There may be some component to that. It's not necessarily, you know, 100%, or it's even a high percentage that you would be at risk for that if your father or mother have a retinal detachment. Certainly, I would recommend getting evaluated by your eye doctor to make sure you don't have any risk factors for retinal detachment, which would include, again, being nearsighted, a condition called lattice degeneration, which is kind of a thinning of the retina and the outside part of the retina, which makes areas prone to holes and tears. So I think just having a baseline dilated eye exam is really important in order to determine if you're at risk for retinal detachment, and to look out for warning signs of this, which include thousands of new floaters, or a dark black shadow of the vision that doesn't move, a black shadow, or nonstop, all day, all night long flashing light. So these are kind of warning signs of potentially of retinal detachment. But again, I would strongly recommend being evaluated by your eye care professional to determine your risk for that. Again, this is separate from what our whole kind of this current seminar is about, which is macular degeneration. So I'll have maybe Jeff kind of chime in on the dry and wet scenario that she presented to.
Yeah. Well, I think the most important thing that you mentioned was, if ever you're in doubt, see your eye care professional. And that just because someone has macular degeneration, it doesn't mean you will or will not get any of a whole host of other eye conditions, whether it be retinal detachment or glaucoma or anything else. So I think the key point there is just really making sure that you have an eye care provider that you trust and you're comfortable with, and that you're able to go see them. And one thing that I would bring up is on the Macular Degeneration Association website, macularhope.org, there's a section where you can click on and find Amd Centers of Excellence. And basically what those are practices that have been vetted by Macular Degeneration Association as being, kind of standouts for taking care of people with macular degeneration. That they're practices that have the appropriate equipment, knowledge base, and desire to take care of people with macular degeneration. So I think that's another great resource when wondering, and especially if you need to find a new eye care provider, to go to macularhope.org and go and find a Centers of Excellence near you. So there's a question, how common is macular degeneration? So I'll take that one. I think, probably the easiest way to answer is the older you are and the older your friends are, the more likely that you or someone in your friend group will have macular degeneration. It's an age-related eye disorder. And so really probably the biggest risk factor is age, getting older. And so depending on how old you are, that kind of dictates the percentage, I guess, of people in your age group that have macular degeneration. Now, what's important to realize about how, as far as how common is macular degeneration, is you'll often hear about two different types, so to speak, the dry kind and the wet kind. And the wet kind is the one that requires the help of someone like Dr. Mali for fairly, for very timely treatment and ongoing treatment. And luckily, that's a fairly small percentage of people with macular degeneration. The vast majority of people with macular degeneration have the dry kind, which certainly can affect your vision, but doesn't generally progress rapidly, and oftentimes doesn't have as much effect on vision as the wet kind of macular degeneration. But I guess what you should know is it is a common eye disease, especially in people over age 60, 65, 75. And something that I tell my patients is, you probably know somebody besides yourself, if you have it. You probably know someone that has macular degeneration, whether they've told you or not. Because if your friends are a similar age group, then odds are you know people that have macular degeneration.
Yeah, just to follow up on that, again, just like Jeff said, most of the cases are actually dry AMD, and what we know is about over 90% of visual loss is from the wet form. So really, there's a very small percent of patients that lose a significant amount of vision from AMD in general. So again, I always it always depends on where you are on that spectrum. It could be it could be a mild case, a moderate case, or a severe case. So really, it does. The key factor is getting yourself evaluated and seeing where you are on that classification scale and seeing what your risk of progression is. So certainly, while it can be a common condition, I think it's important to remember and where you are in that spectrum, and that determines really how much visual loss you may have in the future.
So Josh, there's a really good question here that I'll read off for us. It's from Leona. 2 years ago, I was in a global clinical trial sponsored by a drug company for geographic atrophy secondary to dry AMD. The trial was a phase 3, and in the end, it failed. Has there been any progress on this disease? I understand that currently there is no treatment and no cure for this.
Yeah, that's a great question. So yeah, that trial was looking at an eye injection for treatment of the dry form of macular degeneration, or really a more advanced dry form called geographic atrophy, which is really a breakdown of the very center of the retina in kind of large sizes of broken down tissue. So the goal of that kind of treatment is to sort of kind of slow the progression. We can't really at this point replace those cells, although we're looking at things such as stem cells and so forth down the road. But really, we're just trying to slow that progression, because if you can imagine, the center of your retina has a certain size to it. It's called the macula, and it has a certain size to it. And if this atrophy spot is sort of outside the very center and is small, chances are you may not have, significant visual loss from that. However, if it starts to expand and get bigger and involve what we call the fovea, or the very, very center of the retina, that's when people really report like what we call black spot or scotoma, and that's pretty devastating to vision. So the goal of any sort of treatment with geographic atrophy is to kind of slow that progression, and that's what the treatment that she's mentioning, what the goal was trying to do. And that is correct, it did fail. So you can see how difficult it is to get these treatments to help patients at this point. However, the good news is that there's 2 agents that I know of that are currently in phase 3 trials as well with 2 different companies, and they're so far in other earlier phases have been pretty positive results thus far. So we're really hoping that these injectable treatments will help to slow that progression of geographic atrophy, and I think these look very, very promising. So we should have, I would say, results probably within the next 6 months or so, or maybe even less. So stay tuned on that. But I'm very optimistic that we'll find a treatment for dry AMD. And like I said, I think these are very promising new agents that are out there.
Yeah, the one comment that I would like to add to that, what's kind of interesting about the drug that was brought up in this question was, now I'll preface this by saying we're all hearing all about phase 3 clinical trials right now, right? Because of COVID, vaccine. So we're hearing about phase 3 trials and how important they are. The drug that Dr. Mali was just talking about in phase 2 trials looked like it did great. And then when phase 3 was finally finished and analyzed, that's when they found out it didn't work well. So it's important to really kind of see things through. And the reason I bring that up, and I know this wasn't directly asked, but Dr. Mali, you mentioned stem cells. And I think it's important to note that as of yet, there is no approved stem cell treatment for macular degeneration. And I think that's a really important point to make, because a few years ago, there were a number of places, there probably still are, that were doing stem cell injections into the eye. And there were some people that had just catastrophic results. And so that's why it's so important to find a provider that you trust, and finding a Centers of Excellence from MDA may be one of the ways to do that, to know that you're getting treatments that are in line with current protocols approved and care. Josh, so the next question that came in was, I recently changed my retinal doctor. My new provider gives my injections in the upper part of my eye, which is different from my original doctor. I'm asked to move my eye in a different direction as well before the injection. Are there different accepted protocols for this procedure? I like that. I love that question, because I'd like to hear the answer as well.
Yeah, I would say, the one thing to keep in mind is all retina specialists are different. Everybody's different, has different techniques, different styles. The one thing that's pretty consistent is certain general accepted practices among retina specialists. So for example, I would say all retina specialists will use some sort of what we call betadine solution to help sterilize the eye prior to injection. And this can be different forms, but the one thing to keep in mind is that is a consistent among everybody getting injections. You'll have some sort of betadine antiseptic to be used prior to your injection. That's really important to help prevent infection. There's different kind of other things that are more stylistic. So, for example, some retina specialists use gloves, use sterile gloves. Some don't when they're doing injections. Some use a lid speculum. Some don't. So I think you're going to find variations of this. And then to answer the question directly, the actual injection site, the important thing to remember is the injection site is always going to be in an anatomical location of the eye called the pars plana, which is really a certain location. It's about 3 millimeters just behind, the edge of the eye. So again, we don't have a really model here to show, but it's kind of a certain location on a person's eye. Now that goes 360 around the eye. So you can imagine the pars plana, this place where it's really safe to do the injection, goes 360 around the eye at a particular location. So theoretically, it doesn't matter if it's on the top or bottom or side, as long as it's in that location, it's an acceptable place to do the injections. I would say classically, probably most retina specialists inject actually on the bottom outside part of the eye for most retina physicians. Although, like I said, so, as this case, some people like to inject on the top. So it really depends on a number of factors of where you trained and personal surgical preferences. But all in all, the same anatomical site, the pars plana, is consistent throughout any retina specialist doing an injection.
All right. So here's another question. It's one of my parents has AMD. Does that mean that I'll get it? So that's a really good question, because we know that genetics is one of the driving factors of who develops macular degeneration. So we know that about 70% of what causes or is the reasoning for people to develop AMD is genetics. Now, that being said, just because you have family members, a parent or even two parents with macular degeneration, does not mean that you'll get it. And I guess the flip side of that is, just because you have macular degeneration, that does not mean that your children will get it. It means there's higher risk. And I think that's the thing to remember. It means you're at higher risk, but it doesn't mean that you are certainly going to develop it. So that's a good question. I like that.
And I would just follow up and say that, I think family history and genetics is one of the, what I would call a major risk factor. And the other two risk factors I want to mention, the first one is advancing age. So as we get older, we're at a higher risk for developing AMD. But the third risk, so we got advancing age, we have genetics or family history. And the third one, I think, is really, really a major factor, a major risk factor, is smoking. So I would encourage all the listeners and participants here today to, if you're smoking right now and you have AMD, to please consider stopping smoking, because that's going to be probably the best thing you can ever do, not only for your eye health, by the way, probably your systemic health as well. So certainly those are the 3 things you want to remember. And actually, these are 3 things I talk about on one of our blogs on our MDA website. So again, if you want to check that out, www.macularhope.org. We have blogs, educational videos on there that are very helpful to talk about these kind of topics, because it's important to get education out there about these things, because we can certainly help prevent a lot of these issues with just a little bit of education.
Yeah, there's studies that show that the vast majority of people with AMD don't know that smoking is bad for them, or that they should consider quitting. So you're right, Josh. That's a hugely important point. Kind of what I tell my patients is, when we talk about other things that they may want to address to try to reduce risk, like leading a healthy lifestyle, whether that means exercising or good diet or just good general health. What I always tell them is, any of these other things that you do is taking a step forward, but if you're still smoking, you're taking maybe 2 steps backwards. And so there's lots of things that we think we may be able to do, but we know for certain that probably the worst thing we could do is smoking.
Yeah, and actually, I just want to say one story, and it's interesting that this topic is brought up, because there's actually this time last year, I was actually doing a presentation, this kind of format, when we had the live programs. We actually did one in Sarasota, and I remember, I invited a lot of my patients to attend the event, and it was a couple, and actually the woman was actually receiving treatment for wet macular degeneration. She was getting injections, I believe every 4 weeks or 8 weeks, and she attended the event with Macular Degeneration Association, and I'd said the same thing. I had said, I'd pounded on the smoking thing and said, if you're smoking, please, please quit. And this is a patient of mine that I've been seeing, for a year or so, and I never forget when I had seen her in clinic, and she's like, "Oh, I love the MDA program. I had such a great time. I learned so much more." And she said, "You know what? My husband and I had started smoking about 6 months prior, and we heard you talk, and from that day forward, we were stopping smoking." And she just kind of was so thankful that she heard that message, and it really changed her life. And I can't tell you how important that was to help her disease, because actually since then she was doing great from a wet AMD standpoint. Her disease got better, and we were able to stretch out the shots a little bit further out. Now she's getting shots every 12 weeks instead of every 4 weeks. So, I mean, you can really make a big difference with just stopping smoking. And again, it's just really, really important. And even if you've been smoking for many, many years and say, what's the point? Why stop now? Even if you stop now, you're still going to have that health benefit.
Yeah. So the next question that we got is, do inhaled steroids for asthma contribute to AMD? I was on a steroid inhaler for 15 years, and when I changed pulmonologist, he was horrified that I was on steroids for that long and promptly took me off. It affected the skin on my arms and legs. Could it have affected my retina as well? So I don't know of any studies that point towards steroids being causative of macular degeneration. There's another specific macular condition that can be affected or caused potentially by steroids, but I'm not aware of any association between steroid use or stopping steroid use having any effect on macular degeneration. Are you aware of any, Josh?
I agree. Yeah, I don't think there's any association there. There are other associations with the eye. For example, long-term prolonged steroid use, high-dose steroid use can cause cataracts, glaucoma, things like that, but not with AMD.
Yeah. So the next question is, I've been getting injections in both eyes for 9 years. Can I continue these indefinitely without causing harm to my overall eye health? So I'll let you start off on that one, Josh.
So, I mean, it sounds like, we have patients that have been on injections for many, many years. Again, the first injection was improved back in 2006. So they've been around for about, 14 years or so. We know they're very safe. They have a very good safety profile. And like I said, I've had patients on injections for 14 years, and I'll tell you that overall they're very safe, and the eye appears to tolerate them very well. So I think you should definitely have comfort in knowing that if your doctor has determined that you need them for your AMD, it's certainly the benefits outweigh any risks at that point.
Yeah, I think the other point to make though is that that these injections that we're talking about for most people are fantastic and really afford people to have significantly better outcomes than they would have otherwise. There are some people, however, that don't do well, and that maybe don't do well in the beginning, or maybe 10 years later start not doing quite as well. So even though the injections appear to be safe a decade later, there's still the possibility of at some point having issues with your vision. Now, one of the things I want to bring up to kind of dovetail onto that, and there'll be a whole separate webinar on this topic that you'll all be hearing about, is there's a whole webinar dedicated basically to something called low vision. And low vision is when people have vision that's not correctable with glasses or contacts or surgery, that really just doesn't allow them to do the things they want to be able to do. And so unfortunately, some people with AMD ultimately develop low vision. And what's important to know is there are doctors out there that really specialize in this area, helping you to be able to function much better through different types of magnifiers, whether they be simple old-fashioned magnifiers, whether they be something a little bit newer and some sort of digital magnifier. You've all probably got one of the best low vision devices in your hand today, and that's a smartphone. And smartphones are fantastic for people with visual impairment in some of the things that you can do with them. And so, again, the reason I'm bringing this all up is some people have injections for many years and do fantastic. And unfortunately, some people don't do as well. If you fall in the category of not doing as well with medical treatment, please realize that there's still other treatments through low vision that can help you to maintain your independence and doing the things that you love, whether that's potentially driving or reading or watching TV or whatever it is. So I think that's an important point to make. And again, there's going to be a whole separate webinar dedicated to that very topic. They'll be put on by a low vision specialist who, in his practice, that's all he does. And so he'll be a fantastic resource for all of you to be able to tune into and listen to, whether you need help now or you have questions potentially for the future or for a friend or loved one of yours.
Yeah, the only thing I'd add, is one thing to keep in mind is that AMD, whether it's dry or wet, is a naturally progressively worsening disease. So even though, with time, it naturally gets worse. Now, some people fall at different points on that spectrum. Some people have kind of slow change. Some people have more faster change, faster worsening. Some people are kind of in the middle. And with wet AMD, some people, again, although they're an inactive disease, they still get worsening of their overall condition of AMD. So unfortunately, we can't stop that kind of progression. It's just, that's the nature of the disease state. And that's something to keep in mind, that, despite all our efforts with stopping smoking and eye vitamins and injections, we just can't, there's just a natural history to the disease. But, we hope that we kind of give patients the best chance to minimize progression and kind of stay at a certain or, slow rate as for as long as possible.
So Josh, there's a question: how to tell harmless floaters from early signs of serious retinal disease? And that, that's a really good question, because, Dr. Mali's practice is a little bit different than mine, in that everyone that he sees is sent to him by somebody else for a retina problem. And where mine is a little different is I see anyone that comes in that has any type of eye issue, and probably the most common issue that we have people calling our office about wanting to get seen, quickly, is floaters. And I think the important thing about floaters to realize is that although the majority of the time they're harmless, you don't know that until you get checked out. And floaters could be a retinal detachment, like what Dr. Mali talked about earlier. It could be something very, very harmless and not problematic at all. It could be something related to diabetes, or we could perceive something with macular degeneration to be floaters. the bottom line is you don't know that floaters are harmless until you see an eye care professional that can tell you that there's something harmless. So it's important not to just say, well, there's a few floaters, it's no big deal, it'll probably go away. You're right, it probably will, but if it doesn't, the longer you delay potential diagnosis and treatment, the less likely you are to have as good of an outcome. And so I guess a follow-up to that someone just asked, is there a specific test for floaters? And so really the specific test that we would do if you come into one of our offices is a dilated eye exam, where we put drops in your eyes and it dilates the pupil, makes it big. So the way I explain that to people is your pupil normally when you shine light into it gets smaller. And then it's like looking through a peephole. When we put the drops in, it makes it like a big, huge window that we can look into your eyes much more easily and make sure there's not a problem. So that's the primary thing that I would say that we would be doing. I don't know if you have anything different to add on to that.
No, I think you nailed it, Jeff. That's exactly right.
So we have a question. Are there any specific foods you would recommend that I try to eat if I have macular degeneration? So I love that question because it's empowering you as a patient to be able to do something, right? That you can do for yourself. And so, what I recommend to my patients are green leafy vegetables, primarily because they contain two elements called lutein and zeaxanthin. And fish, I believe, is important. Not just necessarily fish oil, but eating fish is good for you. And the other thing that I point out to people is that it's important to try to eat less complex carbohydrates. So it's the same message that any doctor would be giving you. Eat healthy, more green leafy vegetables, less refined carbohydrates. And if they say, well, what does that mean? Then I say, well, it means less sugar, pasta, bread, and rice. So I think those four white foods, if you can stay away from those, that's a really good thing. Now, incidentally, there's a great book that was written by a colleague of ours. It's called Eye Foods. And actually, you can go onto the Macular Degeneration Association website, and you can find it there. But it's a great book because it not only tells you different types of foods that are really healthy for your eyes and healthy for you when it comes to macular degeneration, but it gives recipes. So it's a really, really good resource for you or a loved one that has AMD because it makes it a lot easier. Me just saying eat more spinach, that may resonate with people, but someone may say, well, I don't really like spinach. How do I work that into a recipe? How do we make that more realistic? So those are some of the foods that I would talk to people about. Let's see if Dr. Mali has anything different that he would say.
Yeah, no, I echo all those same foods and exactly. It's all about moderation and sort of avoiding refined foods. That's really important. But yeah, good healthy diet, exercise. And again, I'm gonna say it again: stop smoking. That's gonna be the most important thing you can do. And I'm gonna keep saying that because I think that's a really, really important point.
Yeah, it is. And an interesting statement you just made was eat healthy, and something that I've really kind of found out is eating healthy means something different to everybody. And so eating healthy may mean, well, I'll just have less fast food or I'll have less fried food. And although that's a step in the right direction, I think we would agree we'd like to see more of a step in the right direction with more fruits and vegetables. There's been some recent literature talking about eating the Mediterranean type diet. And, you mentioned moderation, and the Mediterranean diet is really a lot about moderation. You can have some alcohol, you can have some of this, you can have some of that, but in moderation, as long as you are eating plenty of fruits and vegetables and lean proteins. So oftentimes it's not any specific one food, but a healthy diet or Mediterranean type diet in general appears to be beneficial. So Josh, there was a question, how could Fuchs dystrophy and then having DMEC surgery, so surgery on your cornea, affect age-related macular degeneration?
So I mean, really, we're talking about two separate situations here. I think again, if you think of the eye like a camera, and the front part is kind of like the lens, and you think of it like the cornea and the lens in the eye. and the back part or the retina is kind of the film of the camera. So in this particular situation, if you have something going on with your cornea, in this case, a condition called Fuchs dystrophy, which is sort of a defect in the back layer of the cornea, requiring surgical intervention, it's like having a sort of a hazy or a dirty windshield or dirty camera lens. So it doesn't matter how healthy your retina is in the back part, if you have a dirty windshield or dirty lens, everything will still be kind of blurry. So I would say there's no direct effect to AMD with having these kind of corneal conditions, but I would say that potentially, it's going to affect your vision because you won't be able to see, because that's the first area of your eye that light goes through. So I think it's really important to have a nice healthy cornea in order to help to utilize your retina. But again, there's no association between those two conditions.
Yep. So the next question that just came in is, hang on a second. Oh, so it's actually not a macular degeneration question. It's more related to a retinal hole, and when does that need to be fixed or referred for treatment? So again, it's another eye condition or retinal condition not associated with macular degeneration, and generally it would be if someone's having symptoms, if someone's seeing flashes of light, or if there's fluid around this hole, or almost like a small retinal detachment, that would be someone that would be that would need to be referred for treatment for that.
I'll add that there's also, there's something called a macular hole, which that's what the person's asking. I'm not sure, but a macular hole is something, again, also completely different than AMD. And a macular hole is where you get kind of a break in the retina, but it's in the very center part of the retina from various kind of tractional forces on that area. And that requires surgery. So again, that's a separate condition from AMD as well, but also needs to be addressed with a surgical intervention.
Yeah. So here's a question about smoking. It says, I'm a former smoker and quit years ago. I've been told not to take any supplements with vitamin A as natural beta carotene because that could cause lung cancer. Is there any truth to that? So there actually has been research that shows an association between taking beta carotene and developing lung cancer. I think the more important thing, though, is when it comes to macular degeneration, there's been studies, and you may have heard it, the age-related eye disease study, or ARIDS-2, that showed that taking beta carotene didn't really seem to help, and that actually taking lutein and zeaxanthin in supplement forms, now this is for people with a specific category or stage of AMD, like Dr. Mali mentioned earlier, but that lutein and zeaxanthin are helpful, and they're actually fairly similar to beta carotene, and that beta carotene was not helpful. So, what I would tell you is that when we're talking about things to take because of macular degeneration, not just because of the smoking part, but because of results and knowing what works and doesn't, that there's not really a need to take beta carotene. Now, the other thing that's interesting is, and I hear this all the time, patients ask me, have my eyes changed? Is this better? Do I need new glasses? And if anything's changed, oftentimes I hear a joke about, well, I guess I didn't eat enough carrots. And beta carotene is the main thing in carrots. And what I tell people all the time is that carrots aren't bad for your eyes. They're not bad for you. They're good as part of a healthy diet. But if you want to eat something specifically for your eyes, specifically for your vision, I would make it spinach or kale. So the next question is, I recently had an anterior chamber hemorrhage after an eye injection. What would have caused this to happen?
So I guess it would, a couple things, it'd have to depend on what the diagnosis is. We have injections for wet AMD, but we also have the same sort of injections for other conditions, things like diabetes and diabetic retinopathy and diabetic macular edema, as well as retinal vein occlusion, as well as myopic CNV. So we have other conditions that we use the same injections for. So that's kind of one issue. So the question, patients with diabetes, for example, can develop bleeding in that anterior chamber portion of the eye from blood vessels that grow on the iris or the colored part of the eye. And sometimes you can get bleeding in the anterior chamber from that. So I'm not sure if that's kind of what the participant is asking about. There's also things that sometimes you can get an inflammation after an injection or even an infection after an injection. Fortunately, those are very rare. So, you know, again, it all depends on what the kind of the other factors are in the situation. So that's all I can really comment on.
Okay. So there's a question, why are there so few African Americans diagnosed with age-related macular degeneration? You want to take that one?
Sure. So, I mean, what we know is, again, patients that, you know, AMD is a little bit more common in, more common in Caucasian patients. So patients that have fair skin, again, the idea is that there's less pigment to block out the UV light. And then theoretically you get a higher level of UV light, not only on your body, but in your eye as well. So that would allow theoretically more light exposure, UV light exposure, which can lead to more AMD. So that's kind of what we think is a potential reason why African Americans and other ethnicities that have darker skin usually have less AMD prevalence. However, you know, again, African Americans can also develop you know, AMD as well. It's not uncommon, but it's much lower than Caucasian patients for sure.
So the next question is actually a really good one that I'm glad that got posted, because I think it's a really important one to ask it. And really it's one that may sound fairly simple, but it's what is the treatment for wet macular degeneration? That's a great question, because we kind of, I guess, the way we've been talking, we just assumed that people knew what the treatment was. So Josh, this is part of what you do all day, every day. So I'd love to hear your take on that.
Sure. So when people develop wet AMD, what's happening is there's a blood vessel that grows under the retina. Again, this is an abnormal blood vessel that grows through changes over time. And this blood vessel can bleed very suddenly and cause very devastating visual loss for patients. So the goal of treatment is to sort of starve this blood vessel of the factors it needs to keep growing. I mean, one kind of analogy you could think of is, think of this blood vessel like a tumor. We want to essentially starve the tumor, right? To help to shrink it so that way it gets small over time. So one chemical factor that we know is very important in blood vessel growth and development is something called VEGF, or Vascular Endothelial Growth Factor. So what we've done is we developed medications that can be injected inside the eye that can target this factor. And those are called anti-VEGF inhibitors, so anti-VEGF treatments or injections. And these medications help to starve that blood vessel of this very important factor that needs to help to grow. So you can imagine when you starve the blood vessel, it kind of regresses and gets smaller and becomes inactive. And the goal is to make that blood vessel inactive so that way it stops from bleeding suddenly or causing more damage. Now, blood that's already there or bleeding that's already happened, we cannot essentially do anything about. That just reabsorbs on its own and leads to scarring and visual loss. But if we can catch that blood vessel at a stage where it hasn't bled, you know, so much, then we're able to preserve vision and in cases improve vision with these treatments. And we currently have 4 treatments or 4 different eye injection medications available: Beovu, Lucentis, Eylea, and Avastin. So these are 4 different medications that we have available to treat this. And again, these are eye injections, or we call intravitreal injections. So they go into the white part of the eye, that area that we were talking about before, called the pars plana. We inject the medication inside the back of the eye. It gets kind of dispersed onto the, into the gel and then onto the retina, and it has this effect and helps to shrink that blood vessel. And they've been extremely effective and have really saved, countless patients' vision over time that we've had it approved.
Yeah, the only comment that I'll make to that, Josh, is, and this next comment I think is probably more believable for me than you, just because you're the one doing the injections, is that what patients tell me all the time is when they have these injections done, it's really not a big deal. that they feel very little more than maybe a little bit of pressure, but it is not painful, that there's numbing medication that's used, and that the worst part of it is when you hear about it for the first time. It's not actually having it done. And I hear that universally from my patients. You know, to kind of go along with what you were just talking about, Sylvia asked, can you still lose vision if wet AMD is caught early? And, you know, your best defense against losing vision is exactly as you pointed out, catching it early. There are plenty of studies that show that. There's even a device that you can be using at home that can help you to catch it early, called 4C Home. Again, for people at a certain stage of dry macular degeneration, to try to catch wet AMD early if it happens. So your best defense against losing vision is catching it early. That being said, some people, even if it's caught early, even if they get the injections that Dr. Mali is talking about, some people don't do well. And so, yes, unfortunately, it is possible to have some change or loss of vision, even if your wet AMD is caught early. So Carol is saying, I don't have black spots, rather everything is hazy, like an early morning fog. I've been diagnosed with dry AMD. Is there any way to sharpen my vision and enhance colors? So I think the first part of that is anytime you're asking questions about vision, probably the first step is always make sure if you need glasses that you have an appropriate glasses prescription. That's usually the simplest thing. That's step one. Step two, is there anything that needs to be done by someone like Dr. Mali? Do you maybe have wet AMD that needs injections? And if we assume for this particular case that you don't, you know, again, depending on stage or level of dry macular degeneration, most patients will be on some sort of eye vitamin, a supplement. And the primary purpose of those supplements is to try to prevent macular degeneration from becoming wet. But what I can tell you is there's been a number of smaller studies, so not the age-related eye disease study that kind of mentioned earlier, but smaller studies that show, in particular, for people that take lutein and zeaxanthin, that it tends to improve quality of vision. Now that's a little tricky because it doesn't necessarily mean you'll see things that are smaller, but when you say that it looks like a fog, then maybe one of the things you're experiencing is decreased what's called contrast. So high contrast vision means you can tell things that look like they're black and white. They're very easy to tell apart. Things that are low contrast would be shades of gray, which oftentimes people with AMD start to have issues with their contrast sensitivity. And these supplements, lutein and zeaxanthin, have been shown to be able to potentially help with contrast sensitivity and other things that might make the quality of your vision better. When people talk about vision, they think about 20/20, and 20/20 is a quantity, how big or small of something can you see, but there's much more to vision than that quantity number. So there's a lot of quality that goes into vision, and so sometimes supplements can help that. So the next question from Cynthia is, what's the difference between dry eye and dry AMD? Easily confused.
Yeah, I mean, I would say that is definitely easily confused. And frankly, actually, you know, a lot of patients with dry AMD have dry eye as well. So you know, you're going to see both conditions kind of together. And the reason for that is, so dry eye is you know, kind of focused on the front part of the eye, or the cornea. And it's essentially what it is a condition where your eye is very irritated or dry on the surface of the eye. So again, this could be for a variety of reasons, but this is kind of related to the surface of the eye. Now, dry AMD is again referring to the inside the eye and the back part of the eye and the retina, which is where that disease takes place. So two different locations of these diseases, two separate diseases, but you know, we see with advancing age, both dry AMD and dry eyes. So that's why they're kind of sometimes associated, because, you know, we see them in you know, advancing age. So two separate conditions, but two separate parts of the eye, but commonly kind of we find them together because we see them in older individuals.
Yeah, and I think the important thing there that you mentioned is, we kind of alluded to this before, just because you have one eye condition doesn't mean you can't or won't have another. And that dry eye is very, very common in macular degeneration patients. So there's a question: if a genetic test can show an increased risk of progression of intermediate dry AMD, would you recommend, or what do you recommend for the patient? So I guess that's kind of a general question about genetics and macular degeneration. And I mentioned earlier that we know that genetics drives a lot of who ultimately develops macular degeneration. But something that's important to realize is that macular degeneration is tricky, and it's not just any one thing. It's not just genetics that tells us whether someone will develop macular degeneration or whether they will develop wet macular degeneration. There are two commercially available genetic tests that what they try to do is looking at someone's genetics and try to help predict their risk of worsening of their macular degeneration. And so I guess to directly answer the question, if I knew that someone had higher risk genetics, then the things that could potentially change is maybe I might see that person a little more often, or I may be more adamant about them doing the home testing that I mentioned earlier, 4C home. But regardless of genetics, I think the basic things that Dr. Mali was talking about earlier are what's really important. And so it doesn't matter if you have good genetics or bad genetics. I'll steal his line here: you shouldn't smoke. So smoking remains a really, really important factor. And again, depending on the stage and level of macular degeneration, the use of supplements is important, again, regardless of your genetics. So a question came in, Josh: I have AMD and my kids are asking me what they can do to prevent it for themselves. So what would you tell that patient of yours that says, hey, my kids are asking me what to do, what should I tell them?
And I think the first step in that scenario is to always have a baseline comprehensive dilated eye exam. I mean, that's by far and away the best advice that you could offer your kids, is just to have a baseline eye exam. And again, it really depends on their age. If they're ages 20 or 30 years old, they're probably not going to have any changes. But again, I think it still is worth to have just a baseline dilated eye exam, because again, you might find other pathology that you don't recognize earlier. So I think it's just really important to a baseline eye exam with your eye doctor, and then sort of take it from there. And that's kind of the recommendation will be based on what if anything is found at that point.
Yeah, the one thing that I would add on, because and I see a lot of these patients for those baseline eye exams, and they come in really asking, what else can I do? And I think the most important thing that we can tell, and whether it's related to AMD or anything else, is try to live a healthy lifestyle. And the four things that I tell people are, I bring up smoking, I bring up healthy diet, and the things we talked about earlier, exercising some, and try not to allow themselves to become obese. And I think that's just good medical advice, whether it's in relation to macular degeneration or anything else. No doctor's ever going to tell you, well, you know what, why don't you go ahead and become obese or start smoking? It sounds ridiculous. So I think those are some fairly concrete things that we can talk to our patients about that can potentially really help them, again, from an eye perspective, but also beyond that. So another question is, why does it seem like there's more and more people that have macular degeneration?
Yeah, I mean, certainly that's a good question. And what we're finding is that, number one, there are more people getting, AMD, and it's just kind of what we're seeing is the numbers just going up in sort of epidemic proportion. So I think by year 2050, the number of people with AMD is going to really double. And one of the reasons for that is the baby boomer generation. But also, I think a big component of that is that we're better at diagnosing it better, and we're actually kind of determining cases better. We have better technology, more imaging modalities, and just now a kind of a true diagnosis to call these patients. Because some people will say, well, yeah, my parents, my grandparents lost vision from some unknown reason. So, again, I think we're just better at diagnosing it too. So again, I think the numbers are going up because of our population demographics, but also because we're better at finding it.
Yeah, I think I think you make a really good point. I think the better at finding it is one that's really kind of it's not really considered a lot of the times because 50 years ago, if someone lost vision, a lot of times didn't know why, and so some people don't know about their family history or the genetics of this as it pertains to them, so they're not able to help us to know about that particular risk factor. So another question just came in: how close are we to a cure for AMD? Wow, that's a bold question. I don't know. What do you think?
I think there is always hope. There's always hope that we're going to find a cure for a condition like this. I think that the more realistic scenario at this point is really to improve upon our treatments. Have better drug delivery systems. Potentially have treatments like gene therapy and stem cell therapies to kind of replace damaged tissue. So it's hard to see a cure kind of in the near future, but I do have optimistic hope that we're going to have a cure at some point, sometime down the road. But if right now we want to really just improve upon what we currently have treatment-wise, and again, hopefully progression-wise.
Yeah. So I think I would say that the thing to me that for 5, maybe 10 years that I've been looking for is stem cell. And we're not there yet. There's some trials, but we're not there yet. But I think that's something that may hold promise, but we certainly don't know if it does. So we are about almost done, and so I want to encourage anyone that has any questions to send them in here over the last few minutes. We're happy to answer any of them. So any questions that you have, again, either through the Q&A or through raising your hand. One of the things that I want to point out is that finding someone like Dr. Mali, a retina specialist, if you have AMD, especially if you're needing injections, is really important. And I think one of the things you look for in a really good retina specialist is someone that's willing to discuss and explain things to you and make sure that you understand, just like what he's doing with us today, making sure that you understand what's going on, what's the treatment, why, and all these questions. And so one of the things that I'll tell you that I sometimes hear from patients is that when they go to a retina specialist, sometimes it's a long wait, or they see a lot of people there. And what I would tell you is a long wait isn't necessarily a bad thing, because oftentimes if you're waiting a longer period of time, it's because the doctor is spending more time with patients. And so I think that most of us would agree that that's really a good thing, that you want a doctor that's going to be able to explain things to you. A question just came in: how often should you have a dilated eye exam? So I'll take part of that and I'll hand the other part off to Dr. Mali. The part I'll take is if you don't have macular degeneration, then having routine eye care, depending on age, every year or maybe 2, where you have a fundus examination is important. And Dr. Mali, I want you to say what you think as far as macular degeneration. If you have AMD, how often do you need a dilated eye exam?
Yeah, certainly with patients with AMD, it really depends on where they fall in that spectrum. So, kind of early, I kind of divide them up: early, moderate, and advanced cases. So it really depends on where you fall in that spectrum. It determines really your follow-up and how often you need to be examined. So that's the key. I think it's just where you fall in that classification system. And the only way to find that out is to see your eye care doctor.
Yeah, and some people maybe once a year. Some people, if people that are receiving treatments, you may see some. I would imagine you have some of those patients you see on a monthly basis, and so there's quite a range for what different people need. So Frederick just sent in a question. Thank you. It's would you recommend periodic OCT macular screenings for younger patients with a strong family history of AMD? So OCT is it's kind of like a very fine-tuned ultrasound scan that we can do of the macula to try to pick up very, very early subtle changes. So Josh, I'd like to hear your answer as to OCT screenings for people with a family history.
I mean, I guess my answer is really depends. Depends on, you know, does the patient, if the patient has no history of AMD or no clinical evidence on clinical examination, you know, then again, once you have a baseline OCT, if that's pretty much normal, I mean, I wouldn't recommend getting unless you really see something, you know, even, you know, if you're suspicious of seeing something on actual clinical exams. So again, I think it's important to get like a baseline OCT on pretty much every patient. But after that, you know, really depends on, you know, with your clinical dilated eye exam, if you see something or you're suspicious of seeing something, that's when you may want to consider it. So I think if there's no pathology there, I would kind of, I'm not sure the value of getting, you know, serial OCT examinations.
Yeah, I agree. I agree. So I think there's been three kind of recurring themes that we've talked about over the last hour. And the way that I would summarize those three, and maybe you came up with different things, but don't smoke, try to be healthy, and have someone that you can go to for eye care. Have an eye care provider that you trust, and which I think is a really important part of that equation, so that you're able to get taken care of appropriately if you have a problem or if you ever develop any problems. All right, so I don't see any other, oh, it looks like there might be one last question. If I'm concerned about my eyes, do I go to a specialist first, or do I have to see a specialist first? And I guess it depends on who you ask, right? But you know, I think again, if you go to the macularhope.org and you find one of our Amd Centers of Excellence, I think any of the doctors there are perfectly fine for helping you to know if you have an eye issue. Of course, if you have wet macular degeneration and need injections, then you absolutely need to go see a retina specialist or someone that is comfortable treating that. The last question is, why can I see more clearly outside in daylight than inside in artificial light? My ophthalmologist told me almost 2 years ago that there was treatment that should be available last year, but it's not yet available. Well, so one thing we know about macular degeneration is people tend to not see, with AMD, tend not to see as well in the dark and have a hard time adapting to dark environments. That may be part of it. As far as artificial light, I think that's not necessarily unique to people with AMD. I think anybody would say that they see better in daylight than they do in artificial lights in an indoor environment. So that's a pretty common thing. And then the other part of your question was new treatment that would be made available last year but not yet available. As Dr. Mali mentioned earlier, there's many new drugs in trials. You know, nobody knows what the next one to be approved may be, but you can feel good to know that there are several different treatments in trials that in early trials look hopeful. But you know, unfortunately, we don't know how long things take. I think because of COVID, our perception of how quickly drugs get approved is going to become a little bit skewed. But the reality is that most of the time with FDA trials, drugs take many, many years to get approved. And until they actually get approved, they're not. And what I mean by that is there's stumbling blocks that can come up along the way. And so it always takes longer than what anybody would ever hope for. All right, so Dr. Mali, any closing thoughts from you?
I mean, I think this has been a sort of great seminar. Fantastic to see that so many people were interested in you know, in AMD and taking that key step of, you know, education and learning more about their condition. And it's just so exciting to see. And I wish everybody all the best. And again, we're here as an organization to help educate patients and advocate for patients with AMD. So certainly feel free to visit our website, www.macularhope.org. And again, thank MDA for having me on this panel today.